All right, we can go ahead and get started. Thank you.
Yep. Good morning, everyone, and thank you for attending our Grand Round lecture series. I'm pleased to introduce to you our speaker, Dr. Jeremy Turlington. Who's a native Virginian, born and raised along the coast in Newport News, Virginia. He completed his undergraduate education at the University of Virginia before working as an exercise physiologist at the Riverside Regional Medical Center. Uh, uh, Then during his time, he also obtained an MPH and with a focus in biostatistics from the Eastern Virginia Medical School, and then obtained his medical degree as well. He then came to VCU system in 2009 for his internship in internal medicine and then internal medicine residency, and worked as a chief resident after completing the training. He stayed here for his cardiology fellowship training and took interest in the field of critical care. And after finishing his cardiology fellowship, he completed critical care training here at the VCHS. He joined faculty in 2017, where he spent the majority of his time in our critical care unit, along with time in non-invasive lab in the clinic. We're very grateful for his expertise uh, in the critical care field. CCU to the his topic today is CCU to the CCU to the CICU, evolution of a unit and subspecialty. We look forward to learning from him. At the end of the lecture, we'll leave time for questions. Please submit questions via the chat function or Zoom as they arise during the talk. We are pleased to offer both CME and MOC credits to our Grand Round conference series. To claim credit for today's session, text the code shown at the beginning and at the end of the presentation to 804-625-4041. For questions or to log into your CME Cloud account, visit vcu.cloudcme.com or contact Shannon Winston. Now I'll turn it over to Dr. Jeremy Turlington.
Galpin, thank you very much. I'm going to go ahead and share my screen here to make sure everything comes through okay. All right. Hopefully we're live at this point in time and everything's working. So Galpin, thank you very much. And thank you to the division for having me speak today. I am going to speak about this transition from the CCU to the CICU. It's a real evolution of the unit and the subspecialty, which I have now taken a part of over the past 7 years and did some extra training in. I have no financial disclosures, so we'll move on from there. Our objectives today, because I'm sure it's riveting at 7:30 in the morning, is we're going to talk about history of the CCU. You'll come to find that any of these discussions of this evolution and the need for contemporary training of a critical care cardiologist all is based on history, and every paper talks about how everything got started. We're then going to discuss the evolution from what we call a coronary care unit to a true cardiac intensive care unit, which is more all-encompassing. We're going to discuss the potential advantages of having an intensivist and how that helps with utilization and care of patients. Spoiler alert, there is some benefit to it. And then obviously I'm a little biased. And then finally, we're going to describe the contemporary training model of a critical care cardiologist. So when it comes to the CCU, the most esteemed Eugene Brunwald did say that the CCU is the single most important advance in the treatment of acute myocardial infarction in 1998. But clearly this dates way back prior to this. If we look back in the 1950s, medical literature didn't really talk much about the need for a CCU or even coronary disease in general. At the time, less than 10% of all articles in the British Medical Journal were about coronary disease. And actually by 1964, that had actually dropped to 7%, with most of the articles based on congenital heart disease. But as we know, there are very few diseases that actually can cause such a high mortality within the first month after admission, especially if shock is considered. In which case, per the Swedish Cardiology, the mortality is twice as high. But that's not really the big issue where the CCU got started. The CCU really was started due to ventricular arrhythmias. And we're going to start back in 1947, where a 14-year-old boy, clearly I would assume based on his age, was not based on coronary disease, but was defibrillated from VF. And then in Beck and his colleagues in 1956, they were actually talking about doing an open thoracotomy to treat VF, where a physician, one of their partners, was brought to their unit. They're going to do another procedure. They had a scalpel open. He was in VF. They did a thoracotomy and did actual physical cardiac massage until, of all people, the surgeons arrived to do the actual cardioversion. Further work by Julian at the Royal Infirmary of Edinburgh, he was doing more and more of this with actually open thoracotomy to treat ventricular arrhythmias in the setting of post-MI patients back in 1960. And this is what he realized soon thereafter, is that most cases of cardiac arrest post-MI can really be treated successfully, if the medical staff, nursing, and other staff were trained in closed chest cardiac massage, chest compressions, and if the patient who had an MI, their rhythm was being continuously monitored and was linked to an alarm. And he said that this apparatus could not be or would not be prohibitively expensive if we just had special units that were geared toward this with the special training. And that should be done for 24 hours a day. This is Julian. And he said that he thought that, his hypothesis was approximately 50% of people that died of ventricular arrhythmias could be resuscitated using chest compressions and cardioversion post-MI. He published this in the British Medical Journal, and they actually stated this was completely irresponsible and that we shouldn't necessarily have special units for AMI, that we shouldn't be doing things such as monitoring so closely and trying to push people after MI. And because of that, he left Scotland and moved to Melbourne, where he actually wrote another paper and published it a year later in Lancet and started his own CCU in Melbourne, Australia. It was further a couple of years later in Kansas City that the first actual CCU was opened in America. This was done by Day and colleagues, and he based everything on his first 17 patients. He thought the unifying features should be continuous monitoring with audible alarms, a quote-unquote crash cart where we could defibrillate patients quickly, and a special alert of a team for just CPR that would be to bedside. He also found some contraindications, or he thought there would be big problems, and that there were too many visitors in these units that would have to change. Unfortunately, the electrodes need a replacement every 2 to 3 hours. And a lot of false alarms from patient movement would get people set up, get people to rush in for no good reason. What we actually think of as the modern day CCU was based on this mock-up by Lown at Brigham Hospital in Boston in 1967. You can see here that there were actually just 4 rooms, and that the rooms were paired. And what would happen, there's a wall here with a window. The monitoring system was over here to the right, and then the nurse's station was able to view all the rooms. There was a doctor's room right here in between. But the whole point was this wall in the middle, when there would be an alarm and somebody would have a ventricular arrhythmia, the team would rush into the room and there would be a defibrillator sitting in the window, and they could pull it from one room to the other to actually cardiovert the patient quickly. After the work of Julian and Day, 200 CCUs were developed throughout the world. And like I said, the image I just showed you is from Brigham Hospital at Harvard in 1965. They actually, Lown and his colleagues at Harvard really thought it would be very beneficial to have highly trained nurses, that they would be the best to notice and suppress these arrhythmias and treat them quickly. Part of that was obviously nurses are the backbone of our CCUs and any of our units, but part of it too was honestly because they wanted residents there first, and the residents complained about sitting in front of computers and just our screens the whole time, and quote unquote thought it was scut work, so they rebelled at Harvard, and so nurses were trained to do this. Other things that they wanted to do in these units to treat these patients really work on aggressive pain control, slowing the heart rate, decreasing mental or emotional exertion, while quickly getting the patients mobile and out of bed, which was, very forward thinking at the time, to decrease any deconditioning in these patients post-MI. So Lown actually studied the first approximately 250 patients to come to his CCU. 130 of them had a verified acute MI based on history EKG changes and elevated SGOT. What they were actually looking at, not only were they just defibrillating, they were trying to prevent arrhythmias. So they saw frequent PVCs early in the cycle, short salvos of 2 or more PVCs, polymorphic PVCs, or greater than 5 PVCs in a minute, they were starting patients aggressively on lidocaine, starting at 25 milligrams, bolusing up to 50, and starting a drip soon thereafter, and found that controlling these arrhythmias could really prevent death post-MI. Now, granted, this study was later refuted, but Leon felt that the CCU was the best place to go from intervening at the time to preventing arrhythmias from occurring. Later, I think we recognize the name Killip, but Killip and Kimball of New York Cornell, they actually did something similar in their CCU. They studied 250 consecutive patients. And the first one, they compared those to quote unquote regular care, which at the time was really not even monitoring with telemetry and just slow rehabilitation post-MI over the course of 2 to 4 weeks. The next, they assessed in the same way, but they were actually monitoring them more closely. Now, the first patients, there was no change in mortality, but what they did see is as there was a high mortality, as we previously hypothesized, that if they could defibrillate patients who have ventricular arrhythmias in 60 seconds, they could actually preventively treat arrhythmias, and they could actually, and this is a harbinger for the future, treat the heart failure or hypotension that involved in post-MI patients with shock. Then they could add better attending physician oversight. They could actually reduce mortality, and it fell over 67%. If you go, 2/3 reduction from 26 to 7%. But arrhythmia incidence also fell, and cardiac arrest dramatically fell. They reviewed other data in other CCUs, and again, overall, the mortality in the CCU with these advances, quick defibrillation, better staffing models, and intervening sooner could reduce the mortality post-MI by 33%. And finally, another group, Marshall and his colleagues, looked at 2 hospitals in Colorado. One was the General Colorado Hospital that had a CCU versus the Denver VA without a CCU. And again, found that at the VA, 33% of patients died of arrhythmia post-MI, while only 19 patients died in the CCU setting. So not only talk about history, let's talk about the titles and where these things come from. So again, it's initially a coronary care unit relating to the human heart, but more specifically to the coronary arteries, and really dealing with pathology, mainly acute MI, heart attack, from a coronary thrombosis. We know the current CICU is not like that. Well, what we know, again, is I've told you that arrhythmogenic mortality dropped by about 33% with the advent of the CCU. But by 1980, the shift had gone into more of a cardiogenic shock and ventricular failure. And then by the time we go from 1980 to 1990, you can see here, there's a big drop-off that's continuing from the prior advances from the 1960s to the 1970s. By 1990, the mortality really hasn't changed in CCUs, or at least academic CCUs. So what else is going on? And I think this is the kind of the canary in the coal mine that gets the idea started that there's probably something more than just ventricular arrhythmias, and that there's a need for maybe some more training for patients or for physicians to work in the CCU. So we start broadening out the terms. And it's now the cardiac CCU. It's more in general relating to the heart and a person suffering from heart disease. It's honestly believed now that the CICU, as we commonly call it, or the CICU, the Cardiac Intensive Care Unit, is more all-inclusive and represents the multiple dimensions of care provided. It's not just acute MI. It's not just arrhythmia from acute MI. It's cardiogenic shock. It's arrhythmias for other reasons. There's aortic pathologies. There's pericardial pathologies, et cetera, et cetera. And now, and I'm going to go into some more detail or some more data, that the CCU doesn't, the CICU today doesn't represent the CCU of the 60s and 70s. It looks more like what we would call the MERCU here at VCU, the medical respiratory ICU. Just a nice way to look at a Venn diagram, that the blue is the, again, sorry, here at VCU, we call it the MERCU, the medical respiratory ICU. Most people commonly call it the MICU, versus the CICU. And that you see that there's a lot of, sepsis, GI bleeding, neurologic injury. But what we're seeing more and more in the CICU is lots more respiratory failure, renal failure, and other issues that can be comorbid and complicate the management of cardiac disease. being a little bit more contemporary and getting out of the 60s and 70s, Lichtman in the early 2000s looked at patients admitted to a CICU for an acute myocardial infarction with other concomitant acute non-cardiac conditions. He looked at nearly 4,000 patients and found that at that time in 2007, 7% of patients admitted to the CICU with an MI were found to have other potential severe life-threatening illnesses led by pneumonia, but you see sepsis is quite high too. And then obviously complicating a lot of the work we do, various forms of bleeding, namely GI bleeding. What he found was that most of these patients that had these non-acute cardiac illnesses were less likely to receive aspirin or antiplatelets. I don't think that surprises us if it's bleeding and such. Less likely to get beta blockers, but less likely to get any sort of diagnostic or therapeutic interventions that the CCU is commonly known for. And these patients were also more likely to have bleeding, cardiac arrest, and cardiogenic shock. And overall, they were 9 times more likely to die in the hospital. And if you adjusted for confounders, including age, race, gender, et cetera, they're still 5 times more likely to die of their quote unquote acute MI along with something else. So then there was benchmarking data looking at over 271, and these were including CICUs and almost 250,000 admissions. Of all these ICUs, acute MI was still the #1 diagnosis. When we actually splayed these out between CICU and MICU, you can see the age really isn't any different. The Apache score, and you're going to see different scores, SOFA scores, Apache scores, ways to assess severity of illness, wasn't really that different. Vasopressor use between the two units wasn't different. And I think this might be the most interesting, is that mechanical ventilation was higher in the CICU than it was in the quote-unquote MICU. The most granular and detailed study actually came from Jason Katz, who's now at NYU Langone. He's the associate chief of cardiology there. Jason Katz is, I don't know if he refers to this, I don't know if people do, but he's like the godfather now of critical care cardiology. Trained at Duke and is actually a heart failure attending and trained in that, but also had a real interest in the CCU, especially as it applied to heart failure and cardiogenic shock. He was at Duke and he looked at the Duke CICU from 1989 to 2006. And really the overarching finding was that the complexity of patients was increasing in the CICU and there was actually increased resource utilization. I'm going to show you a bunch of diagrams here, graphs, and we'll look at how the CICU admissions have changed. And the first most striking is that, look at our STEMIs. In 1990, roughly 50% of the patients coming in were for quote unquote ST elevation MI, then it dropped down to about 20% in 2006. But meanwhile, cardiogenic shock was on the rise. So even though we were having less acute MIs, shock in and of itself of a primary cardiac nature was rising. More importantly, other comorbid issues were increasing, such as renal failure, both chronic and acute, and patients with acute respiratory failure. I think it doesn't surprise people. You say there's more cardiogenic shock, there's more respiratory failure, but now we're seeing this come to fruition. More strikingly on the next slide, patients that needed prolonged mechanical ventilation in the CICU had gone up drastically, as had septic shock. So we looked at that study earlier from the early 2000s. You can see where it really took off was in around 2000, 2001. Septic shock increased drastically in CICUs. This is actually from the same data, just a nice, a different phrase from David Morrow at Harvard, that he looked at this. And if we say overestimation of the 17-year period, you can see that STEMI dropped drastically. Actually, so did Swan-Ganz catheters, PA catheters. Meanwhile, primary diagnoses such as sepsis and liver failure were going up, as was the need for mechanical ventilation and bronchoscopy. So procedures that we weren't used to doing in the prior CCUs are very common in the CICU. More recently, in the past decade, Holland at UVA looked at 1,000 admissions to the UVA CICU over a 1-year period for various outcomes, including looking at the primary and secondary diagnosis, looking at outcomes such as length of stay and mortality. ACS was still the prominent diagnosis, and I'll have a graph for this in a moment, at 25%. But now it was NSTEMI greatly outnumbering STEMIs, And I guess they didn't really separate that into true type 1 end STEMIs versus type 2 or other potential causes. But over approximately half of all admissions were for either respiratory failure, acute kidney injury, or sepsis. And you can see this here where it's only 11%. So it's 25% was acute coronary syndrome, only 44% of that. So doing your math, 11% was for STEMI. But other was 21%, was nearly as much as all acute coronary syndromes. At the time, heart failure was only 15%. But we're looking at ventricular arrhythmias, atrial arrhythmias, bradyarrhythmias, et cetera, et cetera. Furthermore, if we look at their, the highest cause of death was going to be cardiac arrest or cardiogenic shock. Respiratory failure and sepsis actually was increasing the risk of death quite a bit too in the CICU, not in other ICUs. And so one of the points they got from this was if you took the patients that came in for an acute MI without AKI, respiratory failure, or sepsis, approximately 1 in 50 would die, 2%. That doesn't sound great, but it's not terrible. But if you added any of those in, it went up to 22%. That 11 out of 50 were going to die in the hospital from their acute MI. So these comorbid issues that we're seeing more and more of as people live longer and have other health problems really drive issues and mortality in the CICU, which is why they really plateaued in roughly 1990. Sinha and his colleagues actually reviewed these findings on a much larger scale. They were reviewing over 3.5 million Medicare admissions, and they were finding, as you can see here, the cardiac are in the red or red hues here, while non-cardiac diagnoses are in the blue to gray hues. And you can see that over the decade that they looked at, coronary disease dropped, but everything that actually went up in the non-cardiac disease were mainly infectious and respiratory illnesses, and actually to over 50%. Meanwhile, non-invasive ventilation and renal replacement therapy were increasing in the patients in the CICU, while angiography and Swan-Ganz catheters were decreasing. So our patient population is much more sick with a much more complex history at this point in time. Formerly, Marcos Cachioris, who was here as an intensivist, along with Mike Contos and Shaw Roberts, they actually looked at the CICU illness with a SOFA score, the severity, compared to other ICUs here at VCU. And they looked at 8,000 admissions to the various ICUs. You can see that the CICU, and this was back in 2016, so I was looking at the few years before that, I think 2011 to 2014 or so, that the CICU SOFA score was equivalent to that of the MERCU. And though it doesn't really maybe show it out on this graph, actually it was statistically more sick. These patients were statistically more sick than patients in the STICU or the neuroscience ICU. CSICU were considered the sickest of all. And actually at the same time, over the time frame they studied, that the mean CICU SOFA score went up significantly more than any of the others. So it was, again, talking about the CICU patients were becoming more and more sick, even over shorter periods of time. So despite improvements in cardiac care, mortality rates have stagnated, and it's likely due to these non-cardiac comorbid conditions that are increasing over the same time period. So that's what's actually gone from the CCU, where it's rapid resuscitation, you start getting some advances in technology, but recognizing arrhythmias, treating arrhythmias, to then actually becoming very comprehensive. And it's not just arrhythmias, it's mechanical support for cardiogenic shock. It's therapeutic hypothermia for cardiac arrest. It's using our renal replacement therapies such as SLED and SCUD that we've talked about with our nephrology colleagues. It's using ventilators and using more advanced modes of ventilation to support these patients. So the CICU is the proper definition because it's much more comprehensive at this point in time than it was in the 60s and 70s. So with changes in severity and advances in technology, how can staffing changes help improve patient care? And this, I gave you this bit of a spoiler alert. I'm going to now defend the need for an intensive care physician to get a better idea of what we can do and how we can maybe help these patients get better and reduce mortality, length of stay, et cetera, et cetera. But to do that, we have to start with the different staffing models first. We're about open versus closed staffing, low and high intensity models, and there's hybridized models out there. So the open ICU, just to state it now, we have a closed CICU here at VCU. Open CICUs are managed by any individual physician. Intensivists are not routinely included in the assessment. This is a lot of the smaller hospitals. I'm going to use the word level 3 now. Remember that. I'm going to come back to that. As opposed to closed ICUs, it's an ICU-based physician. I'm not going to say a critically care trained physician yet, but it's ICU-based. And then hybrid ICUs, they're admitted by a primary physician, but there's always an intensivist available for consultation. So, sorry, we're going back a little bit, 1989. And Brown and his colleague and Sullivan, they looked at the hypothesis looking at open versus closed ICU. This was in Canada. And what they actually did was they looked at patients who were admitted about 220 in 1 year when the ICU was considered open. And then they looked at the difference up to 500 patients, another 200 and some patients, and after they closed the ICU. And what they found was the Apache score, looking at mortality, wasn't really different between the 2 years. What you can see is that patients that are sickest with the highest Apache score, they're the most likely to have a higher mortality. But when they went from an open to closed unit, mortality dropped in half in the ICU. Importantly, hospital mortality dropped too. So there may be something to said for setting these patients up for success when they get out of the ICU. They don't have complications later, which is dropping hospital mortality. Carson and another group prospectively looked at converting an ICU from a open to closed model. It's another 250 patients. And what they actually looked at was the predicted mortality and then what the actual mortality was afterwards. And they found that there was actually a smaller, the predicted and actual mortalities were closer in the closed ICU, that you could actually train these patients and there wouldn't be a big swings that the patients were sicker, but they were actually surviving at a better rate. There's no difference in resource utilization. So even though these patients were sicker in the closed unit, they weren't taking up more utilities in any way. And other things that were found were the nursing staff reported they felt much more confident in the decisions made by the intensivist in the closed model, which is maybe another something to think about in here. That's not just the physician, but it's the training of the nurses and the way the staff works together to take care of patients in an ICU setting. Now, so that's open and closed. Another way to think about it is low intensity versus high intensity. So low intensity is very much like an open system where a physician can admit to an ICU. There's not necessarily intensivist care. It's elective. It's whether they include an intensivist or not, versus a high intensity where it's a closed setting and intensivists have to be consulted. Now, I'm not referring specifically to CICUs at this point in time. This is ICU settings in general. I think we see this in some of our other ICUs. Think about our cardiac surgery intensive care unit, surgical patients, and though they're consultants, the attendings up there, the anesthesiologists, are critically care trained. So that's the idea of a high intensity. There's an intensivist seeing these patients, even if they're not the primary person, they're being involved in their care. So Pronovost and his colleagues actually did a systematic review of approximately 26 studies, mixing medical, surgical, pediatric, neuro. And what they found is that in high intensity staffed ICUs, the mortality was better in nearly over 90% of these studies. They also found a lower mortality overall when you took all the studies combined, in the high intensity versus low intensity staffing models. The thoughts are intensive improve outcomes because they're just more familiar with the acute illnesses. They've seen this more often. They know how to react. Because this is what they do for a living, they're more up to date on the literature and can apply more evidence-based medicine to prevent complications. Because their job is to be the intensivist, they're not away from the ICU, they can provide more urgent care. And then they can facilitate use of multidisciplinary teams. The idea of multidisciplinary teams is beautiful. I'm going to talk about one study there, but it's really out of the scope of this talk. Just know that having more, two heads is better than one, and just broader groups is probably more beneficial. This was a study in Pennsylvania looking at multidisciplinary care. There's over 100,000 patients admitted to various Pennsylvania hospitals and divided them into low intensity without multidisciplinary care versus low intensity with and high intensity with multidisciplinary care. And multidisciplinary care includes higher nursing level of acuity, pharmacists, physical therapy, occupational therapy, a lot of the allied health professionals. And they were found that patients who received multidisciplinary care on top of low intensity, so the lower two categories, had a reduced mortality. And the lowest mortality, not surprisingly, was in the high intensity care plus other people helping out, including the allied professionals that I discussed. Venari also did something similar, but looking at just CICUs. 2,000 patients, 2 years. This multidisciplinary team looked at a cardiologist plus an intensivist. So they were not necessarily, the cardiologist not necessarily trained in critical care. They had fellows, nurses, respiratory therapists, and a pharmacist. And they found that if you see the CICU mortality, the hospital mortality, the length of stay, et cetera, ventilator days, all were better in the patients with the multidisciplinary teams. They also came up with daily checklists. We use the quote unquote fast hugs list in our CICU, and that would also help prevent harm to patients, work on infection prevention, ventilator weaning, and early mobilization. And if you go up to our CICU now, plug for us, if you look at mobilization, our patients with Impellas and balloon pumps and getting patients off ventilators, our checklist and SHA helping out, we do this every day. And there's a lot of benefits that's coming out in the literature now about these on top of mortality with other outcomes. Specifically looking at a cardiac intensivist, we have to go to Korea, South Korea last decade, but Na and his colleagues looked at over 2,000 patients consecutively admitted to their CICU. 600 received the low intensity, 1,800 received the high intensity, which meant there was an intensive care physician, a cardiologist and an intensivist, and the mortality decreased by 50%, both unadjusted and propensity. Sorry about the alarm downstairs. The effect stayed significant, but less so once ECMO patients were removed from the data set. We don't do ECMO in our CICU, it's in the CICU next door, but there was a reduced mortality regardless. Oddly, there was no difference in ICU or hospital length of stay in this group, but mortality was better. And this just goes to show you, not only was it cardiac, they spaced this out with cardiac mortality, non-cardiac mortality, sepsis, and it was actually reduced risk in bleeding, and it was not in malignancy for what that's worth. So if CICUs are becoming more complex, there are more ill patients, and the evidence points that an intensivist can help improve patient outcomes in some way, shape, or form. How do we train intensivists now to staff the CICU? And so O'Malley and his colleagues actually sent surveys to CICU directors looking at this. 55% were closed units, 91% were cardiologists, 9% were intensivists, 4% of these were dual certified in cardiology and critical care. About half of them had an intensivist that was available for consult, so thinking more like a high intensity model. And a 10% didn't have any intensivists available at all. And what we came to find was 87%, so this top here, these two were agree somewhat or strongly agree that the closed ICU was better for patient care. However, only 50 or so percent felt that, and these were mainly cardiologists, felt that an intensivist was needed to care for the patients. And they felt that the cardiologist had appropriate skills to care for patients in the CICU. But oddly enough, 80% said we still need more training in critical care for cardiologists. And 58% of them said that they think select CICUs should have a critically care trained cardiologist. So look at this, was in 2012. And what do we mean by select CICUs? Well, back to David Morrow at Harvard, he proposed that CICUs should now be tiered or leveled 1, 2, and 3, much like surgical trauma ICUs. And that when we look at this, that level 1 is what we would have in our CICU, all cardiac diagnoses with various comorbidities. You have advanced heart failure, STEMI capability, 24 hours a day. They talk about include post-surgery care. Maybe not all CICUs have a CSICU next door, and have a full spectrum mechanical support, mechanical ventilation, et cetera, renal replacement therapy. a lot, that they can handle any of these illnesses that I pointed to a few minutes ago that can confound care for a cardiac patient. A level 2 should be able to handle most things. They have STEMI call, maybe not 24 hours a day, but they can urgently take care of things. They can do temporary support. So maybe we're talking about a balloon pump or a CP impella. You have access to EP, but maybe not EP procedures, et cetera, et cetera. And then level 3 is going to be, you can diagnose and stabilize patients with common cardiac conditions, but you can't do any of the advanced. You don't have a cath lab on hand. You don't have an electrophysiologist, no advanced heart failure. So those patients need to be transferred out to a higher level of care. And this is where we actually go into the idea, what does a critical care cardiologist need, or what units need a critical care cardiologist? So we have cardiology. As we all know, our fellows train for 3 years. Here they get a lot of training in the CICU, but are these fellows who are now graduating and going to cardiology, are they going to CCUs, and what level CCU are they taking care of? And if not, what are intensivists being trained for in a cardiac perspective? And so this was a survey of various intensive care physicians. Half were pulm critical care, what we think of in medicine as the traditional pathway. A third were surgical, and then you can see another 20% were anesthesia or just critical care by themselves. And what they found is those fellows were very confident in a lot of procedures, except for cardiac issues. They didn't trust their judgment on pacemaker malfunctions. They didn't understand acute valvular disease. They weren't comfortable with balloon pump placements. They weren't comfortable with pacemakers and pericardiocentesis. The things that we would need typically in a CICU, they weren't comfortable with. They were instead comfortable with more of the typical mechanical ventilation, bronchoscopy, the stuff that cardiologists don't routinely do. So again, how do we then grow on this if cardiologists aren't doing the procedures that intensivists are doing but are needed in the CICU, and intensivists aren't comfortable with the CICU patient with the cardiac issues? Well, a few years after David Moreau talked about the need for levels of CICUs, the ACC put out a COCATS level requirement for critical care cardiology, just like we have for interventional or EP or heart failure or any of the procedures. Dr. Tallahassee checked our fellows off when they graduate. They actually put levels in for critical care cardiology. And to be level 3 COCATS trained, it involves an additional 1-year fellowship in critical care medicine through a department of internal medicine on top of the 3-year cardiovascular fellowship. And then most contemporary, meaning October of 2024, a panel was put together by the ACC to talk about how do we train cardiologists with critical care for our needs. Andrea Elliott, she's at the University of Minnesota. She headed this up along with Haim Bardwaj and Gautam Tallahassee. We've actually chatted with her, and now we're going to talk about Trey Whiteside in a few minutes about what we're trying to do here at VCU based on these recommendations from literally 8 weeks ago. The take-home point and the reason for this was critical care cardiology is rapidly expanding. I say rapidly, but we can go back about 60 or 70 years, and that these trainees should have at least 12 months of additional training on top of cardiology training. The next steps will be to actually come up with a training model and standardize it across various skills, competencies, and then locations, so we can broaden the training and we can broaden the field so we can take care of our patients as we need. Because as we now see, it's a very fluid case mix that comes in the CICU. It's not just acute MIs and heart failure now. And as these patients are higher acuity, they need better staffing to take care of this. Some of these pictures are a little busy, but this is now trying to talk about what are we needing to train. And this working group used the tiers of CICU to talk about what training is needed, with the idea being level 1 is just a picture format of what we already talked about. If you're going to work in a level 1 CICU, they would recommend training for being COCATS level 3 with an extra year of training on top of cardiology fellowship. Now, here's the catch with all this. not all hospitals have a level 1 or even a level 2 CICU. So not all cardiologists need to learn the skills to manage patients in the level 1 CICU. When I was graduating and Dr. Guzman was here, he goes, you haven't really come through my cath lab. He came after I had started. And I said, no, sir, I'm actually going to do critical care. And so I spent my elective time doing more MERCU and CSICU. He goes, oh, well, that actually makes sense. So I didn't do a lot of cath labs. I knew I was going to the cath lab. Not all trainees need level 1 training in CICU. But conversely, not all training programs have level 1 CICUs. And so not all trainees are seeing the acuity that we see here at VCU and a lot of these CICUs. And so it would be unfair to throw somebody who trained at a smaller program into our CICU and expect them to compete at the same level. And so the idea is that over time, staff CICUs, level 1 CICUs, should be staffed predominantly by critical care cardiologists, though just because a cardiologist not trained yet doesn't mean they can't care for patients in CICU, in a level 1 CICU. If they have a desire and they want to learn and they can stay up to date, as long as there are some intensivists there help guiding, this could work. But over time, hopefully we'll get there. Unfortunately, the need for cardiac critical care physicians is outpacing the supply. And so there are a lot of parameters impacting that right now. There are not many programs that are actually training in critical care for cardiologists. It's quite opaque trying to figure out what programs are training and then how do you apply to those programs. There's variability in training, though I told you the ACC is recommending 12 months as at least 12 months. Traditionally, a critical care fellowship was, if it was not along with a pulmonary fellowship, was 2 years. I will tell you from my own experience, ABIM does give credit for ICU care in the CCU, and so it can actually be the number of months needed for ICU training can be reduced if you've done a cardiology fellowship, so it could fit into a year, but not all programs are doing that. And then furthermore, are there other subspecialties such as advanced heart failure or interventional, or maybe you can mold that with a critical care year and it could be done in 12 months or 18 months, but there's variability. And then the additional training delays these cardiologists from entering the workforce. But all in all, the task force recommended that it would be a preferred training of a 3-year fellowship in cardiology, followed by an additional dual certification in critical care medicine. Now, not everybody does it. There's also looking at a 2 and 2, where there's 2 years of cardiology. The 3rd year is blended between cardiology and critical care, and the 4th year is critical care. But in any way, it's going to be for 4 years. The last thing that I would say, and I don't think they talk this much in the paper, I've read it multiple times now, is that I think the fellows need to be able to sit for critical care boards. I think if you're unable to sit for critical care boards, it's really going to, at times, lower their ability, or at least the thought that they can work in some of these level 1 CICUs if they don't have that other training. We can't prove it. It's hard to, I'm going to show you in a moment, some of these competencies are hard to come by. And at least if there's board certification from ABIM, that would be helpful with getting these patients or these physicians into the CICUs. The other thing is right now, cardiology, ACC is working on a separate cardiology board, and they talked about interventional, advanced heart failure, EP, the traditional ones. There was no mention, at least at that time, of cardiology critical care, which is another potential parameter that could slow some of the training. All critical care cardiologists, trainees must complete that cardiac training, but they need experience in non-CICU ICUs. So think MERCUs, think neuroscience, and an extended time in a CSICU. That's what Lisa Brath did for me when I was a critical care fellow here. Was a lot of my elective time was next door in the CSICU, managing patients with ECMO and some post-cardiac issues. But these experiences should include, and are not limited, this is not exhaustive in any way, ECMO, neurocritical care, difficult airways, palliative care, and then some of the things that we don't always think about, ICU nutrition, and then other chronic morbidities that can become critical or acute and confound the picture for the cardiac patient. Sorry, this is such a small slide, but this is actually looking at a typical curriculum. And what you'll see is they still recommend that after completion of a cardiac fellowship, 1 month of CICU time. I did 2 weeks. I don't, you need a little bit, probably not a lot, but 3 months, I would say maybe 3 to 4 months of MERCU time, 2 months at least of cardiac surgery. And then there's going to be other needs for potential advanced heart failure, other procedures, mainly airway, intubation, bronchoscopy, et cetera, et cetera. But then other elective time, including, like I talk about ethics and palliative care, ECMO cannulation. I did a little bit of that. And then maybe some talk about transplant or infectious disease issues. And in the end, this is probably the slide that I want to bring up. This is what a contemporary critical care cardiologist should look like. They should be in green, the general cardiologist that can manage acute coronary syndrome along with the cath lab and cardiogenic shock, and can talk about advanced heart failure options with our heart failure attendings, and talk about arrhythmias and treat those acutely while we get EP on board. Meanwhile, they need to have some MERCU skills. They should be able to talk about bronchoscopy and thoracentesis, lots of lung ultrasound and management of septic shock and other illnesses, such as renal replacement therapy. And then some CSICU with use of ECMO, and talk about pre and post heart transplant. And you can see some of the other skills in these Venn diagrams that overlap, that are going to take a lot of various skills that take more than just a typical 3-year fellowship. Future directions, I thought I was going to be running slow on time or low on time, and I'm getting there, so I'll leave some questions. But, really what we need is we need this curriculum. We need to establish and advertise critical care fellowships for cardiology fellows. We need to potentially address these joint fellowships with interventional advanced heart failure. I think you looked at those competencies on the last slide, and you need to be able to streamline. I would argue that there's a lot on there. I don't do a lot of those anymore. And you work in a tertiary quaternary care center like this, and I don't necessarily need to do a bronchoscopy when Wes Shepherd is a 2-minute phone call away. There's the skills I learned, but do we need all of those competencies? Can we streamline that a little bit? And then how do you maintain them? Maybe I don't intubate for a certain period of time. Do I lose that skill? Can I keep up with other forms? Do you get other stakeholders involved, groups such as Society of Critical Care Medicine or CHEST that does workshops to keep up with skills? How do we go from there? I put Trey on here. Trey Whiteside is our newest cardiologist, and he is the Renaissance man because he did interventional cardiology and critical care. And if you look at this map, these are the programs that have trained somebody in the past decade. And I put the little circle here because you see VCU is right here, and University of Kentucky is where Trey did his training. So we are actually having meetings with with Lisa Brath of Pulmonary Critical Care about trying to broaden this out. There will be more than just he and I that we can train here, and maybe we can add to the catchment of critical care cardiologists. So in summary, the CICU, the CCU of the 50s, 60s, 70s has grown to a truly comprehensive cardiac intensive care unit with a wide swath of cardiology patients with many comorbid non-cardiac illnesses that affect what we do for our patients. The use of intensive care physicians has demonstrated improvements in outcomes, including reducing length of stay and mortality. But currently, if we were to go to these levels of CCUs, the demand for cardiac critically care trained physicians is outstripping the supply, and we need further training opportunities to go from this conceptual framework to something more concrete to meet the demands. I want to acknowledge all the fellows, nurses, pharmacists, and the allied health professionals that help us care for our patients in the CICU. I want to thank all the attendings, both that work in the CICU, who aren't critically care trained, but have the desire to be there and want to help our patients. And then our team. Every paper talks about history, and every paper tries to make a sports analogy and call the cardiac critical care physician the quarterback or the point guard of the team. But, here at the Pauley Heart Center, it really is. I can talk to the interventionist, the electrophysiologist, talk to the advanced heart failure attending every day, imagers. We do this together to take care of our patients. And I really want to thank Mike Contos, Haim Bardwaj, and Shaw Roberts with some of the growing pains post-pandemic and such. As a team within a team, they really help keep me in line, and we've tried to really work together to take care of our patients. And I want to thank them for their support. And with that, Gautam, I'll turn it back over to you in the chat for any questions.
Thank you very much, Dr. Turlington. This is a wonderful lecture, and your insight into the possible program which should come up soon is quite interesting. Now that I mean, now that we talked about further training and that, additional year required for critical care, and while a few other subspecialties are evaluating in the model of 2+2, like EP, which is 3+2 usually, do you think 2+1 would be enough for critical care training if it is tailored towards uh, doing more critical care during the 2 years of fellowship with a 1 year of critical care director training in other subspecialties?
That's a good question, Gautam. The 2+1 model hasn't honestly been brought up at all in any of their research so far. It's always been 3+1 or two plus two. I don't know. I do think, much like anything that's a procedure, even though critical care in itself isn't a procedure, you need lots of time. And unfortunately, unlike being in an EP lab or a cath lab where you're at the table, you're doing the work, it's all about exposure to whatever's coming in. So I think it might be a little hard to cut down to 2+1 to make sure. And I'm not sure if we're still, I'm going to go back a little bit to keep up with some of the needs, with our TTE and getting your TTE, TEE numbers and POCUS if we're doing that, along with feeling comfortable with floating Swan-Ganz catheters and some things, because you need that experience in the cath lab or placing temporary pacers. There's a lot there that I think it really cramming that into twos would be difficult to then get your extra year. But I would be open to that. I think, if you're trying to do your CCU, CICU time, and then other ICUs, it is possible, but I think it might be a little harder to meet all the competencies right now.
Okay. And would that, would the 2+1 model at least help in the interim where there's lack of appropriately trained critical care attendings when there is significant demand but quite short supply?
I mean, that's one of the things they talked about. I'll tell you that the paper by Andrea Elliott and the working group really kind of put down the idea of the advanced, like doing critical care with advanced heart failure, which I think is really key because so much of our patients in the CICU, are advanced heart failure waiting for transplant, and didn't think that doing the 3 years of cardiology and then critical care and hybridizing that with interventional or EP or advanced heart, they kind of, my take on it was it wasn't well liked. So, I don't know. It would definitely help with numbers, but I think we have to also think about what numbers are we doing and what care are we giving to, not throwing a bunch of people out there if they haven't been trained fully.
Okay, thank you. I have Aaron who put in a few questions. He thanks you for the informative talk. He has 3 questions. First question, in your opinion, what would be the role of artificial intelligence and remote monitoring in improving the outcomes and diagnosis of various cardiac conditions in the cardiac intensive care unit?
I saw this. I was looking over at the chat and such, and leave it to Arun to ask questions about artificial intelligence, which I know very, very little about. But I think, if you go back to when I think about some applications of artificial intelligence, maybe going back to the original CCU and what was there for, ventricular arrhythmias, maybe artificial intelligence can get a better idea. One of the things that Jason Katz has written a lot on is, does every NSTEMI need to come to the CICU now? And I think we debate this as attending and fellows, that we need to bring this person or not. And maybe artificial intelligence can look at maybe other risk factors and better stratify patients so we can better utilize the resources we have and not put patients that aren't needed in the CCU. As we know, sometimes we're fighting for beds and stuff. So maybe that's where artificial intelligence right now can maybe help suss out some of the other comorbid conditions or risk factors for these patients so we can maybe treat them earlier a little bit more appropriately.
Okay, thank you. And the other question, do you believe there has been a lag in starting critical care cardiology fellowship program across the country? If yes, why do you think was the spark that caused the rise in these programs?
Well, there clearly has been a lag. I think part of it really goes back to the opacity. Really, what got me interested in critical care cardiology, and I swear I can never seem to find this paper, or maybe I just don't read it well enough, was there was a paper I thought in circulation written by Jason Katz So maybe it was David Moreau and Jason Katz, and they were talking about the need for critical care cardiology. I was like, oh, wow. And that would have been my second year of fellowship, which would have been 2013, 2014. But at the time, it was, I think, a lot of siloed people on islands going, yeah, we think we need this, but there wasn't anything bringing everything together. And I'll be honest, for better or worse, I think the pandemic really got people realizing, well, wait a second, we have people with cardiac disease and we've made our changes here in 2020 and going, well, but now the people they have respiratory failure and is that all MERCU, but they have cardiac disease and stuff. So I think the pandemic is what was like the kind of the straw that broke the camel's back to have all these places that I showed on that map go, we need to get together and figure this out for ourselves. And we need to be more cohesive as a group and not all just doing our own island and our own training.
Okay. The third
And then I
question is
see,
there any need?
go ahead.
Sorry. Is there a need for standardization of CCU setting and staffing across hospitals?
I mean, I think eventually there is, but I think what we do is maybe it would be standardizing the CCUs and the different tiers or levels that was brought up in 2012. I would have to ask Mike. I probably should ask him yesterday. Is this really borne out yet in CCUs where they have certain accreditation or certain levels that's hard and fast? But I think that would be an impetus to more defining what the needs are for critical care cardiologists.
Thank you. I have another question. Would you think that someone who is trained in 2 years of general critical care would benefit from accelerated program if they're interested in cardiology or cardiac critical care?
So say that they 2 years of general critical
So
care.
there are some certain programs which offer only critical care training for 2 years. Would if they're interested in doing cardiac critical care, what would be the process? Is it additional year or 2 years? What
Yeah,
would be?
that's a really good question. It's going back to your numbers and trying to get more attendings trained. Every once in a while, I'll come across somebody who did it. I'll say backwards. That comes as a negative connotation. That did critical care and goes, I like cardiology, and they do cardiology, and that's 5 years. So that's actually another year on top of that. But I think unfortunately, to really be proficient in cardiology, you need your 3 years of cardiology we've talked about. I think that would be a little strange. So I think if we can treat critical care cardiology the way we treat interventional or advanced heart failure or EP or imaging, and you can then get people that are already cardiologists through the 1 year, at least that'll condense it down a year. But I think it'd be really hard to do 2 and then 2 of cardiology after the fact. And then I think the other problem with that is maybe you're losing some of your competencies or skills from critical care because you're having to put so much into cardiology, you can't spend the time with the bronchoscopy or whatever it may be.
Okay, thank you.
Well, I think that's it, Galtham. If I look at these.
That's it. If anyone else has any questions, you can ask now, or else we'll end the conference.
And if not, most of you send me an email, or if you have my number, call me, text me, whatever it may be. I'll be happy to answer any questions. Thank you all very much for the allowing me to speak here today. Have a great day.
Thank you, everyone.
Thank you, Dr. Turlington.
Thanks, Shannon.
Have a good one.
You too.
Thanks.